So when we do the diagnosis of a smoldering myeloma to a specific patient, so we do the diagnosis based on the presence of a monoclonal component higher than 3 grams per deciliter in serum, and or a plasma cell bone marrow infiltration between 10 and 60%. But so patients are completely asymptomatic and there is not any myeloma defining event. So during the follow-up, the first important concept is that we have to monitor these patients. And we have to monitor them according to the risk of progression to myeloma. So if the smoldering myeloma patient is at low risk, maybe we can monitor this patient just once per year. If the risk of progression to myeloma is intermediate, maybe we can monitor these patients every 6 months. And if the risk of progression to myeloma is high, I think that we can potentially plan an early intervention, or if we don't want to plan an early intervention, we have to monitor them maybe every other month. And during these visits of follow-up, I think that it's important to do an hemogram, biochemistry, including creatinine and calcium values, but also to monitor the serum protein studies, because we are going to check the M component, and the M component during the follow-up is going to give us an extremely important information about the evolving pattern of the monoclonal component. And we can potentially identify patients in which the M component increases over the time. And this is an alert, because we know that in these situations the risk of progression to myeloma is going to be much more higher, and maybe we have to take care about these patients, and we can potentially plan an early intervention. The question mark during the monitor is the imaging assessment, because it is not well established if we have to repeat MRI or we have to repeat PET-CT, and maybe if it is possible and the resources are available, it would be ideally to plan an MRI and or a PET-CT once per year, but there is not any formal recommendation.